Then we have probably a PVC, and then a pause, and then what look like now sinus P waves, so kind of sinus tachycardia for 1, 2, 3, 4, 5, 6 beats. That's the last sinus P wave, I think. And then, again, the reappearance of this more abnormal looking P wave with kind of a shorter, if you want to call that a PR interval. And I think the rate also speeds up here. So this is at like a rate of 150.
What do you mean it speeds up? As it goes along? Or it's just faster?
No, like as in here we were going sinus tack at like 100,
okay,
a little over 100.
So you mean it's a different rate?
And here it's a different rate. Like it's a different rate and probably a different rhythm.
Well, why do I ask that? Because you use the term speeds up.
Yeah, so that implies that like there's a change in autonomic tone and the sinus rate increases.
Well, often it implies a mechanism. It's not a good thing to remember, but people use that term to think of a warm-up, of an automatic focus, and that's something I don't want you to. It's really bad. I mean, I remember I learned that before I knew a lot of EP. Warm-up phenomena. But the truth is, any kind of arrhythmia, even a reentry arrhythmia, can become a little faster as the circuit accommodates. All right.
Sure.
So I just didn't want. I mean, in other words, you have two separate rates, is what you're saying.
That's what I meant. Yeah.
Okay. Go ahead.
Actually, I think what's happening here, like at the end of the strip, and what's happening at the beginning of the strip, is probably the same thing. And
I'm not sure what you mean by that.
What I mean is that the same kind of P wave, the same heart
tachycardia.
rate, the same tachycardia is happening here on the left side as on the right side.
I totally agree.
And it's broken by a PVC, and then...
Broken? Do we have to send it out to get fixed?
Yeah, ended by a PVC.
Or terminated, yes.
Terminated by a PVC.
But it's not broken, I hope.
Well, not because it's back here.
Oh,
so clearly it's not broken.
Back.
So, okay.
Self-healing tachycardia.
So it was injured. And
it came back, all right.
And then you had some sinus tachycardia, and then the resumption of this narrow complex tachycardia. So then the question is, what is it?
You've gone through it beautifully. Now start to tell me what it is.
Yeah.
Now, you have to, I think I'm fine with you. You start with that. So you made an observation here. There's two separate kinds of P waves, right? So remember my lecture yesterday. Let's just start with simple things. And again, you asked the three of us, we'll all pick this apart differently. But, this is kind of like how I like to look at it. So tell me about the P waves in 2, 3, and ABF. Just look at these two. It's easy.
Yeah, so I mean, they're down going in 2 and 3. So they're going from the bottom up.
Yeah, caudocranial. Yeah.
Sure.
Bottom up.
Caudocranial. And they're...
narrow or wide?
They're like normal widths. They're not as narrow as the ones that we saw yesterday.
Measure this versus sinus. I know it's hard because we're giving you clubs here to measure. It's either equal or a little more.
Yeah, a little more.
Okay, so where do you think it might be coming from? So that helps you in putting your tail together, right? Is it coming, I mean, like remember George said, do you see something that's clearly maybe in lead 1? It's hard in something like this, right? Because it's P wave's over here somewhere, so I don't see a totally negative in lead 1.
Yeah.
All right, that might, remember George pointed out yesterday, that might send you over to the left. Yeah, but that doesn't mean it isn't somewhere else on the left or the right, but it's clearly not in the septum per se, anterior septum, or you'd have a narrow little P wave. Okay, so remember we talked yesterday, long RP, short RP, I mean, so would this be definitionally what? Which would you call it?
Long RP.
Long RP, okay. So you got a long RP tachycardia.
Or a short PR tachycardia.
Or a short PR tachycardia. In Canada, everything is reverse.
I'm from Canada, so yeah.
Oh, so then you should have said a short PR tachycardia.
See, the only reason I say this is because you don't know whether the R is driving the P or the P is driving the R.
Oh, I'm just descriptive. So, I'm not making any claim to what's driving what.
No, I know you're not, but he doesn't know that necessarily.
Well, he's from Canada.
Well,
He
what
just
the
tell
hell?
you.
We have smart people. We have, what's your
Don't
last name?
say it, George.
Oh, my last name's Hungarian, but
Oh, I'm Hungarian too.
oh, okay, small world.
Well, does that wait?
Basically like
Wait.
again.
Does that mean he's a smart person then, or what you were gonna say?
Well, there are smart Hungarians and dumbass Hungarians.
So here's the thing. He's playing with you, but the reason this is just a definition that implies, remember I said yesterday, no mechanism, it's just a starting point, and it doesn't mean anything mechanistically, but there happen to be clues on this one that you are going to get to that you haven't said yet, right? Okay, let's go back to this part. You could take it either way, and to where it terminates, right?
Yeah.
So the question I'd ask you is why? Do you think it was just fortuitous, PVC, and it terminated? Or do you think the PVC maybe had something to do with the termination?
Yeah, so I mean, if you think of the differential for a long RP tachycardia like this, or just in general, I would think, could it be, atrial tachycardia? Could it be atypical AVNRT? Could it be AVRT with a pathway?
Perfect.
And
That's
I think
perfect. Don't go any further.
Yeah,
That's perfect.
So,
You got it.
and then it's terminated by a PVC. So I think atrial tachycardia would be less likely to terminate with a PVC.
Good.
AVNRT would be
Less likely or off
not
the list?
like very
the
unlikely,
list.
off
Okay.
the list.
Unless it were a huge coincidence.
Right. And then AVNRT would be in the middle, and AVRT would be most likely to terminate with a.
Okay, but you could actually make some measurements here, right?
I could.
So you can make some measurements. So think about this now. Do you have EP background? Have you done a little EP?
A little bit, yeah.
Oh, it sounds like you've got some background. So you have the PVC and you have the tachycardia. So I want you to think intracardiacs,
Okay.
intracardiacs. So in a PR interval, there's an A, an H, and a V.
Mm-hmm.
Okay? So position for me where you think the hiss may be. So that's easy, right? You could just go along. You know the hiss has to be somewhere in the PR interval. So pick a point. I don't care. Just pick a reasonable point. HV is usually 40 milliseconds in front of the V. So go for put your calipers down and kind
Somewhere
of put
the
two in
middle.
your. You got to do two things. You can't
Sure.
put one. Okay. Okay.
Like that?
Well, not in the middle of the P way. Move it off a little bit.
These are hard.
I know they're hard. Life is difficult. I know. Life is difficult. Just think of all those people who are like sitting on a corner and can't even afford breakfast. So you're not that guy. Life is not that difficult. So here, now move it over to. Okay, so it's a little late, right? So the PVC is coming a lot earlier. So what I want here I'm trying to get you to do is, if this PVC is occurring here, and you walk that back and say, where is it in the cycle, right? So if this is the theoretical HH interval, and you move it over, you're in there somewhere, but it's not. It's kind of early, right? And why am I doing that exercise with you?
I mean, I think you're getting at whether this would be like hiss refractory or.
Well, yeah, and George loves to show tracings like that. And if sometimes it's like right where the hiss would be, and goodbye, go home, the diagnosis. This was a little bit trickier, right? Because it comes a bit earlier. It's consistent with, but it's also not ruling out. It's not ruling out something like AV node dependent. I mean, a long RP because of AV node. So I'd like you to make another measurement. Measure the RP here.
Okay.
Okay, and go measure the RP over there during tachycardia. No, you mismeasured that. Okay, hold on. I know it's not so easy. Here, maybe, okay, let's see. It's almost the same. It's close, right?
Sure.
So this is something you just have to know. In fact, I remember George, when George and I both left Duke together, he went to Canada, and he started this whole new system there. He got, I think it's fair to say, George, you became like almost Canadian center for a lot of the PSVTs.
We were the first EP lab in Canada.
Oh, I thought I thought maybe there was one in Toronto. I didn't realize that. So Menashe didn't have a lab?
He had a physiology lab.
Oh,
He didn't
physiology.
do EP.
That's what I thought. So I remember George and I, we wrote papers together for a while. We would always communicate. We were good friends from training. And he was starting to see certain things. I remember he educated me on them. He said, you know, Eric, I know people said this, but I haven't seen it. And that's why I'm trying to show you this. This pattern of how this starts, and then you suddenly go in here. So first of all, tell me what the sinus rate is doing preceding the start of tachycardia. These are the sort of subtle clues to this rhythm. Oh, just take the one before versus the one you start with. Is the sinus rate speeding up a little bit from the start? I mean, here, take that PP and take the one here.
It seems to slow down, if anything, no?
What? Here, put your PP here.
Yeah.
Don't squeeze them. Measure. There's your PP. Okay, and how about that? How's that slowing?
Okay, fine. Speeds up.
Canada. What do you want?
All right, so
you at PR that I couldn't tell back there when he blew it up. It was clearly prolonged, but it would only prolong a little bit. With good high quality calipers, you might be able to figure it out. So you speed up, and then you're in tachycardia with almost the same RP interval. So not only would your PVC, like George said, hardly ever stop atrial tach to begin with, you wouldn't expect the atrial tach just to start with the identical RP interval. I mean, could it? Yeah, but it'd be pretty damn unusual, right? I mean, it's like we've said, it's probabilities we deal with ECGs.
The word is linked. Everybody uses the word linked.
I hate that term, though. You know
do
that.
You?
Yeah, I do, because Massoud used that instead of transeptal concealed conduction.
I know, but nobody knows that. Now, I think by common usage, the word
linked?
has been morphed into the fact that if the P is married to the QRS consistently, then
so that's the
linked. So nobody knows Massoud's stuff anymore.
Oh, okay. Well, because I'm going by something Massoud did, and I hated the term because it really wasn't the classic term. Anyway, okay, if that's linked for you, I'm with you. Whatever you want to say. So they are the same interval, unlikely for an atrial attack. So now you just have to go what's most likely. If you're going to say this is not an atrial attack, and I 100% agree with you on that, for all the things George said it ain't going to happen, I'm going to tell you that it starts with the same basic link, whatever you want to call it, RP interval, okay? And we're going to guess it's not atrial attack. You have two choices. So what is the more likely choice? Do you think it's more likely for that to be an atypical form of AV node reentry? Or you think it's more likely to be an accessory pathway mediated?
And there's two ways of looking at this. One is just probability, and you either know it or you don't. But when you see this type of tachycardia, it's a little different than in an infant or a young person versus an adult. But in general, we know which one is going to be the most prevalent one when you see that. And maybe that's what he's asking you. And the second thing he might be asking you, is there any direct evidence for that? I think there is a little bit. But the starting point is, and you either know it or you don't, what in an adult, let's say a 35-year-old adult, what would be the most common cause of this long RP or short PR tachycardia, all right?
So I think in general, AV-NRT is more common than AV.
In general, but not for this type of tachycardia.
Oh, because it's long RP. So then.
Well, no, it's how it starts. It's not just, it's this speeding up of the sinus rate. It's actually how it was initially described incorrectly by one of the brightest guys around at the day, Philippe Coumel. He got it wrong, right? He talked about the PJRT was not, the J was wrong. It's PAVRT.
Yeah, so that's the most common. The most common is probably by far in an adult.
Oh, yeah. Well, you're the one, when I was talking, you said you kept studying these people and they all turned out to be wolves.
Exactly.
Accessory pathway. So I started thinking, I didn't know that he had this whole referral base. And I knew this from training days because John Gallagher and Will Seeley had just taken someone like this to the OR. When I wasn't involved, I was a fellow, but he had done it before, the year before. And they found that it actually was an accessory pathway. Now you have to understand, you all can say, yeah, whatever. But in the days when you didn't know any of this, to go in the OR and realize that it's not the AV node that Philippe Coumel was writing about. It was a pathway, and they went in and they cut a left posterior septal accessory pathway, and tachycardia ended. It was kind of revolutionary. It was like, whoa, these are not it. Because we were all taught these were AV nodes, and that was the first demonstration that it wasn't the AV node. And then George was seeing him clinically, during his early years and telling me, Eric, I haven't seen one AV node. So I began to realize, I suspect that's just wrong.
Yeah. So
It's
most of
wrong.
the time, let's say out of the box, I'm not going to swear to these statistics, but 90% are going to be pathways. So I call this PJRT type of tachycardia, all right? But it has 3 differentials, as you pointed out. It's an AT, AVNRT, or AVRT, and that's it. And in an adult, AVRT is by far the most prevalent. In pediatrics, I've seen a lot of atrial tachycardia that looks just like that, huh? And of course, you give it a little adenosine, maybe in a pediatric case, and you see lots of P waves and nothing, all right?
You're home free.
Yes.
But I haven't really seen too many AV node reentries do this.
No, I haven't. No, not too many AV node reentries. But I've seen them in adults, but
Pretty rare.
You've heard your mic on,
And
Ken?
I'm sorry. It's pretty rare, and although the P wave is inferior, if you look in V1, it's mostly positive. And to have a positive P wave like that in V1 means that the vector of atrial depolarization is coming from posterior towards V1. So posterior part of the heart is the left atrium. So I'm guessing this is a left posterior accessory pathway, or you're going to show a slide of an EP
Well,
stuff.
sure.
And
That wouldn't leave you hanging like my buddy George.
And again, I think there's just a real pearl how it starts. Without a PR prolongation, which of course you can see with atypical, but it's just so consistent.
and when you're done, I mean, I wouldn't mind just switching over to my computer just to summarize.
Yeah, no problem. Let me just do this, and then we'll go back to George's summary. So you did, by the way, you did a great job. I mean, I use this term a lot because it's a way I like to teach. I think George probably can too, but certainly I like to do what I call peel the onion, because everyone kind of knows a superficial approach. That's not why we're here. We're supposed to be teaching you second, third, fourth, fifth level down. So don't take it the wrong way if you don't know it. I usually will keep going till you don't know something, because with few exceptions, I will, because of my years in the business, know more than you do. And you may get the first 3 right, and then I'm going to do something stupid like say, well, who first described it? And you're going to okay, I think I ought to sit down. But you did a great job, and we'll let George summarize. But this is the intracardiac. Can you all see this here? Why don't you step, would you mind just come over just so they can all see it? So this is the patient in the lab.
Or you can let them sit down too, man.
Oh yeah, well, sit down. You did a great
Even
job.
better.
Thank you for coming up. Thank you very much. So you can see this is the patient in the lab. Here's the typical P wave you saw. It's really just mimicking what the ECG showed you, right? And if you see tachycardia, it's coming up the left. It was probably a left posterior septal, left a little off the septum. I don't remember. It was a while ago we ablated them. You can see it's in the R's. I'm into the S's, so it was at least 2 years ago. But anyway, it's coming up left side, but really close to the septum. And then we put a PVC in here, probably very close to the His. I can't remember if it's exactly on the His. And tachycardia terminates without going to the atrium. At a time the His is refractory, game, set, match, ablate, go home, okay? So, but it was all on the tracing. I have personally not seen that kind of tracing ever be AV node reentry. I've just never. Now, I've seen that long RPB AV node reentry, but not the way it started. I just never have seen that. I'm not saying it doesn't exist, but if you gave me 100 such tracings, I'm going to always call it AVRT. And if I'm wrong once or twice, so be it. I'm going to have to figure it out in the lab anyway. You're going to do your own things. You're going to do adenosine. You're going to pressure on the carotid, do all the clinical things when you see them. But I'm just telling you, from a probability standpoint, I think both these guys would agree. If you ask on a quiz, what would be your most likely diagnosis? AVRT is the answer.
And I think he said that.
Yeah. So, George, you want to put up?
Yeah, if you can just go to my slide set for a second there, Matt. And just to summarize, by the way, the fact that the tachycardia started with a slight acceleration of the sinus rate is classical for the Kumel type of tachycardia. And these patients clinically, what do they present as often?
Cardiomyopathy.
What symptoms? Cardiomyopathy, dyspnea, heart failure, huh? because a lot of them are not aware of being in tachycardia. And these pathways have some autonomic variability. So if you did someone in incessant tachycardia and you haltered them, you'd see some diurnal variation, because that RP moves just like the AV node does to autonomic. So the patients with incessant tachycardia will get cardiomyopathy, but especially if they don't have a good diurnal variation. So if they slow down to something respectable at night, then they're less likely to have a myopathy. So they often present with heart failure. That's why we always look for tachycardiomyopathy with heart failure. So just to summarize it, because in the spirit of summarizing, this is the way I would look at it. I'm framing my problem as a long RP, short PR tachycardia. The P wave is low to high, little positivity in V1. So this fits with that category of PJRT type of tachycardia. Now we're lucky enough to have an offset and an onset. So I'm going to take this onset and I'm going to exclude everything but the area of interest, right, like that. And I'm going to blow it up until even I can see it. I'm going to take my calipers here. If I can pick up on my calipers, where are they? Can't see. Oh, there it is. All right, thanks, guys. Much appreciate your help with that. And I'm going to pick, as Eric said, pick out the hiss. About there, 50 seconds. And put out another hiss. Come on. Right there. Hiss is about there. And I'm going to move one over, and I'm going to ask myself, is it hiss refractory? And you can't be absolutely sure, but it's still a relatively late coupled. Now remember, a PVC that gets into the circuit relatively easily is going to be big reentry with big excitable gap. You're not going to get into an atrial tachycardia with a late coupled PVC. In fact, you're not going to get into AV node reentry with a late coupled PVC. It has to be tight and has to get in there. Whereas in AV reentry, the ventricle is part of the circuit. So you've got a big circuit, and that only leaves you with AVRT. So even though you can't see the hiss, it's still relatively late coupled. It's not strictly speaking hiss refractory, almost. So it's late coupled and it terminates it. If it terminates it without a P wave, it cannot be atrial tachycardia. Very common board question. If a V terminates at SVT without getting to the atrium, it cannot, of course, be an atrial tachycardia. You can take that to the bank, and then the subtlety is whether it's AV node reentry or AV reentry. So this offset is AV reentry, all right? And now I'm going to look at the onset, to Eric's point, and what he has told you was that there's an acceleration of the sinus rate, which is quite obvious here. We can do that. I'm not going to do it, but you can see that the sinus rate accelerates, and this first RP is more or less linked to the rest, which would be a huge coincidence if it were atrial tachycardia. So I agree, Eric, we're using the word wrong, but sometimes the wrong word sticks, even though the fact that it's wrong.
I agree with you there.
PJRT sticks because we know it's not PJRT, right, but it sticks. That's why I call them PJRT type of tachycardia, because that stays true to my fetish for semantics, but it also is relatively, as I know, it doesn't matter if I get it right and you get it wrong if nobody knows what I'm talking about.
So, and I published in a review paper, I called it PVART, and it fell flat on its face. Nobody picked up on the term, so I stopped saying, it's just like first degree heart block. It just ain't going anywhere. But the point is, please understand the term is wrong. That's what we're both saying. And I like your way, like is fine, but it's just all started because a very, very, very smart electrophysiologist wrote an article, and he did schematics, and he showed where it was. Who knew? We're talking back in the days before, in the early 70s and stuff, and it was that's what we're thinking. They didn't know there was a lot of slow pathways. I mean, they didn't think accessory pathways were slow. George and I published the first paper on decremental pathways. Remember, during our training, people didn't know that could happen. So in the early days, it was reasonable for Philippe. with, to kind of do a mind experiment and work it out. And it was only after the OR proved he was incorrect that people sort of started looking differently.
Well, he tweaked to it himself after a while, but he wrote his articles in book chapters.
He brought it in a book chapter, Total Conduction of the Heart.
Yeah.
And an archives Malcourt.
So those of us who like, as you get older, you like history better, I don't know, because, history is your history. But the important part is the approach to the tracing, which I tried to show you. Overview, frame the problem, look where you're going to find the money, the beginnings, the ends, and use physiologic principles, because if you don't have those, all the tools in the world aren't going to help you. But you see just by what I did on this computer that it makes things much, much more evident, doesn't it, to see exactly what's going on. Take the area of interest, shut everything else out, and focus on the area of interest. And if I do this, I bet you I can get it down to within 10 milliseconds accuracy, 5-10. You're not going to do that on paper, even Eric, although he probably does it better than anybody.
10 seconds, no. I'll go 20.
There's a question,
I get a 20.
There's a question, I think, a virtual question.
Yeah, what is it, Rich? What is it?
Oh, yeah. There's a question about the P wave morphology in V6 excluding AVNRT, and I just pointed out that it doesn't truly exclude AVNRT because you can have left-sided slow pathways.
Yeah. I will say this, though. Oh, yeah, correct. There are cases I've published, and probably all of us have, it's no big deal, where AV node reentry will break out even in the mid-CS because of the pathways, atrial pathways. But I'll tell you what I've never seen with AVNRT. I've never seen a P wave negative in lead 1, because even though the activation on the CS is there, the left atrium doesn't get activated there. It goes back, right? So the sequence on the CS, which is not the left atrium, the CS, if you go and look at a heart and dissect it, the CS does not abut the left atrium. So it doesn't give you a negative. I've never seen a negative P wave. So if you're in the lab and you see this, pattern coming out CS and you think it's AV node, look at lead 1. If lead 1 is negative, it's more likely, that means left atrium is activated earliest. And in AV nodes that I've had with the funny pattern coming up on the left, I've never seen the left atrium activated before the septum. I've just never seen that. So look at lead 1. It's important to see if there's a negative P wave. Now, one last physiology point, then I want to move on to the next case.
Wait, before, I just have one more quick point to add to that. Here's the question for those of you who weren't involved. I think the question is whether that negative P wave that I'm pointing to here means that it's eccentric left-sided pathway. And you know what? I agree with that. I know that AV node reentry the AV node can come back to the atrium off center a little bit, and even rarely farther left. And Sonny Jackman shows the case, but he's been showing the same case for 15 years now, so I'm not sure it's all that common. You don't want to bet. On it. If it's coming out left, don't bet on AV node reentry. Huh? Right. Don't throw out AV node reentry. But it's very low on the list, right? So it's a very big mistake to think that that's no good. If I see this, I'm betting heavily it's going to be a left-sided path.
Absolutely.
All right? And I can tell that by,
So one last thing, and then we'll move on to the next case. Why do you think the speeding up starts it? I mean, we told you the phenomenon, but what do you think physiology is going on, any of you? Think about it.
Think of the circuit. So why does a speeding up of the sinus rate suddenly allow a circuit to go in? You know the reentry circuit, right? You know the criteria for reentry, right? You have to have 2 pathways. You have to block one, and you have requisite slow conduction in the other to find the previously blocked pathway out of its refractoriness. So if you have a slowly conducting, not so hot pathway, what do you think is physiologically going on as the rate increases? I think you're all kind of getting it. The fact is these are very, very poorly conducting pathways antegrade. By the way, if you block the AV node, if you created complete heart block in this patient, now you're not going to, whoever gets this right, I'm going to actually buy you something. Because you had to read one case report, and I'm not thinking you read it.
So if you cut the AV node, what do you think? Do you think you'll have a delta wave? You ever think of that? Critelli. Okay, you're going to say no. Everyone in the world will say no because these are unidirectional, right, pathways with slow conduction, except in the days before they were able to do things we do now. They actually took a patient, this was published from Duke, I wasn't involved, I think it was Critelli's patient, brought it over. John, they created complete heart block because the patient was in trouble. I think they were myopathy and stuff. And lo and behold, post-op, this is a wonderful picture. I'll never forget reading this case report. There's a P wave and a god-awful long PR interval with a delta wave. So this person actually had the ability, if you allowed enough time, to make it over. So I'm not going to say that's true for everyone because they didn't then go and blade everyone's AV node, right? But there's at least one case out there where they prove that they actually have it. So if you think about that, then it's extremely slow conduction, often long refractory period. As you speed up the rate and slowly conducting tissue, you prolong, not like His Purkinje. So I think, George, that's the reason this is classic. As you increase your sinus rate, it's a pathway with amazingly decremental conduction, long ERP. You probably finally block any antegrade penetrance, and now you're off. I mean, that's how I explain it.
So the only thing about that is that many of these pathways, even though they have a long RP interval, are not necessarily decremental. They have a slowly conducting pathway, but it's not decremental in the sense that if you put a PVC in, you prolong the VA interval.
Yeah, I didn't mean it that way.
So you have to define decremental versus slowly conducting.
Right. So that's one physiologic point.
But slowly conducting pathways classically have a longer ERP.
Yes, they have a longer
Okay.
ERP. Secondly, if you bung up someone's antegrade accessory pathway, like you ablate the AV node and somebody has a Maheim pathway, or mistakenly ablate the AV node and someone has a posteroceptal pathway, so you destroy their AV node and you leave them with basically some heart block or conducting slowly over a pathway, and you say, well, I don't know how reliable that pathway is going to be. I can't send a young patient out without a pacemaker because what happens if their pathway fails? They have nothing. People died from bradycardia before there were pacemakers. So you put a pacemaker in, and what you create is a perfect circuit for pacemaker-mediated tachycardia, incessant, because they still have retrograde conduction over the pathway, and you just put in a brand new AV part of you replace their crappy accessory pathway with the pacemaker antegrade conduction. So they conduct to the ventricle, then they conduct right back up to their AV node, right back up through their accessory pathway to the atrium, and then the pacemaker sees the atrial activation, paces the ventricle, conduct back up again. So you create an incessant pacemaker-mediated tachycardia, which there's only one way to fix. You got to get the pathway.
Right. Good point. You have one more question? Yes.
Question about, so wolves, we know, have antegrade conduction, sometimes infrequently, intermittently, whatever. Phenotypically, wolves are different than patients with concealed accessory pathways with retrograde only conduction that we see. Is there an embryologic or other distinction between patients who have antegrade conduction versus not that you guys are aware of?
Well, I know the anatomic studies, but most of them have been done on people with documented pre-excitation. George, I don't know if there's
I did a case report at Duke with Don Hackle. You remember Hackle?
Sure, Don, yeah.
So we had a patient, but similar to that. But what happens, the theory is that the heart has a rocking, twisting motion. So the natural history of antegrade conduction is to get worse with time because it's a stress on it. So that's why a lot of the people start off with bidirectional conduction, and with time, the antegrade conduction tends to disappear even. So you don't see a lot of sudden death in older people with the WPW because they've passed the test of time, and their accessory pathways often worsen with time. So they're the same pathways. And one of them is thought to be due to the stresses and strains of
I'll do one more, then I'm going to turn it over to you.
of the heart beating that gets rid of the anterograde conduction, and the retrograde conduction seems to be more robust.
So anatomically, there's no
No
significant
difference. No
Okay.
difference.
Thank you.
Now, and there are several there's several Beckett, there's several nice reports out there. I think the consistency is that the pathways are often slanting and they're thin, and but don't forget, it's really hard. It takes a ton of time to find a pathway. So if somebody never had one, it's unlikely someone would go through all those sections to try to figure it out. So most of the literature, maybe except for yours, have dealt with documented pre-excitation, and then they've died and they've dissected the hearts. And there's not a bunch of those articles out there, but they all kind of show that, right?
Well, the Becker and
Wrong.
Anderson has, I think, published 7 or 8 cases, but then there's the Japanese guy published about 80 or 90 cases. You know, the Japanese count everything, and they like to count things. So they went through about 80 or 90 of them.
Forget you heard that.
This wasn't a pejorative. In fact.
Oh, well, anyway, so they have 90? Really?
It
That's
was a
lot.
large case
Did
series.
they show anything different, though, than Becker and Anderson did?
No, they didn't show
I
anything
think so.
terribly different, but the pathways are generally in the order of microns long, so they're not long
Yeah, they're not
pathways.
real long.
So they're short pathways, so I think that the pathways, this is a little esoteric, but they slant functionally in that the atrial entrance don't coincide, they're separate. My personal view is, since these pathways have not been shown to be 3 centimeters long,
Yeah.
is that they're probably taking a ride in the CS somehow and coming out differently.
Probably, yeah.
It makes more sense than a long pathway that nobody has seen pathologically, all right? So that's a little esoteric, but I mean, you're starting, and I guess maybe the teaching point that's worth remembering is that the A and the V sides of the pathway do not always correspond. And that's what Eric means by slant. They don't correspond.
Yeah,
So when you're ablating, let's say you're having a bitch of a time getting it from the anterior side, if you want, then you say, "Oh, I'll change the plan. Maybe I'll go to the atrial side. It
Yeah,
might be a little
and
easier."
the other most important part of this is how you measure things. So you're measuring through the CS. You're not doing direct atrial measurements like we used to do in the OR, when you put the measuring, your electrode right across point by point on the atrium. I'm just telling you, the CS is 1.5 centimeters away from the left atrium. And if you look at, I know you haven't read these, but if you look at Roger Barr's earlier work looking at how electricity spreads, it's very, very Barr and Spock's early work. If you take a microelectrode 2 millimeters off of a Purkinje fiber, the electrical field seen is already well dispersed. So now you can imagine you have 5 millimeter electrodes, right? Remember George was telling unipolar versus bipolar. Most of the things we measure are bipolar. Let's say they're 5, okay? And you have a catheter sitting out 1.5 centimeters looking at activation. And that's where you screw up. And that's where people like Sonny, frankly, tried to make this all about this huge slanting. Yes, maybe in the CS and how, like George said, these pathways come up. There's a very complicated musculature on the CS. And like I said, you can go out and back on the CS. The Japanese, ironically, have published, I don't remember the paper, very nice paper, showing double potentials. And you can see the difference. The first potential's like the pathway, and the second one's the CS versus the classic, just the CS by itself. A whole literature on this. So you're measuring things that aren't on the heart. So you get something here, and you think, like George is saying, the pathway goes from here to here. No, the anatomy that's been published does not support that. That's what George is saying. But you're measuring incorrectly. You're measuring far away from the action, and the electrical field produced is different than when you're sitting on the actual atrium mapping. When you're in the lab and you're making your measurements, VT and all that stuff, you're not putting a catheter in the middle of the ventricle and take some virtual, electrode. You're trying to get point by point, but that's not the CS. So there's a lot of measurement error. I'll stay with George on this. The anatomy does not support long pathways. I will tell you a trick, though. If it's a concealed pathway, always move on the left side 1.5 centimeters to the left of where your earliest CS point is, because we know from the OR days when John was there with Sealy, they do slant slightly, lateral to medial, slightly. So like a sonometer. So if you're measuring, the VA interval and you're ready to do your ablation, if it's a concealed, I always tell the fellows to move it over about 5 to 8 millimeters, because that's actually where the actual insertion is. And that's where but anyway, we're way beyond electrocardiography. I'm going to show you one more and then turn over to Ken, because you got to know this. But we can do this one from your seat. This is the tracing. And I ask a very simple question. I ask two questions that I want you to ponder. Number one is, what will you do with this patient? And number two is, what's the mechanism? How's that? Two questions. Yes, you're going to take the first one, right? Good move. Tell us who you are here. You want to come up? You don't have, if you want, you can come up and measure it. I mean, this is one of these eyeball things, right? I mean, you'd have to. I mean, you don't really even need calipers on this one, right? So, who are you?
I'm Kavisha. I'm one of the first-year fellows at UCSD.
Okay, we have. Oh, you're going to bring all the way over there. I was actually going to just bring her this one.
So she needs exercise.
That's right.
So go for it. Yes.
I'm Kavisha. I'm one of the first-year EP fellows at UCSD. So I think this is a pause-dependent or bradycardia-dependent AV block. It's also called phase 4 block.
Well, ooh, I'm so sorry. Wait. How come? Pause-dependent AV block.
So the first 3 beats are sinus. That's followed by a P wave, followed by a long pause.
Stop. I'm going to slow you down a little, followed by a P wave.
APC. Yeah.
No, it's okay. You want to talk to me about this P wave versus this P wave? This is an ECG course. We're going to take you down a few layers. Mm-hmm. Yes, you're right. I want you to be more right.
It's a premature.
More right? I don't know. Go ahead.
It's a premature atrial contraction.
It's what?
It's a premature beat.
Yes. Look at the dimensions of that P wave versus the sinus P wave. Is it wider, narrower, or the same?
Skinnier.
Skinnier.
Mm-hmm.
Why? Why is it skinnier? Where do you think it's coming from?
Probably close to the conduction system, like the septum.
Yeah, probably right in the anareceptal area, right? Mm-hmm. You'll see where that becomes important in a second. Okay, and then, so you have a PAC, okay, maybe, but there's certainly atrial activity there. You don't actually know where it's coming from at the moment. Could it be starting in the atrium, or where else could it be starting?
Near the junction.
Well, near the junction, does that mean in the junction or just near the junction? And by junction, you mean AV node, NH, AN, HIS, right bundle, left bundle?
No, in the AV node.
How about we make
area.
it simple? Do you mean AV node or HIS?
AV node.
Do you mean, you sure we want to say that?
I would say so, yeah.
You sure? Okay. Very good. All right. So anyway, then what happens? Then you have a Brady-dependent block.
I'm not sure the answer was it the HIS? I mean, it could be the HIS,
I'm
right?
just going to let her go for a while. I have an intracardiac.
Okay.
I'm going to let her just fly for a while. I mean, because here's the thing. Here's what she's going to say, which I can't refute. She's going to say, well, how do you know it wasn't right before the HIS? Because the HIS is the only thing we measure. So see, I know that where she's going. She's going to say, you can't prove that, Prostowski. Just because the HIS is there, it could have been the late AV node, and it caused the HIS. So I'm going to give you that one. But HIS is a better answer. So anyway, and then you have a whole bunch of what?
P waves and no QRS complexes.
What do you call that?
It's complete heart block.
Well, it's not complete heart block, right?
The block is at the level of the HIS and
no, but I mean it's not called complete heart block, right?
high-grade AV block.
High-grade AV block, right? And I don't know how to define that. You know, it's kind of a Potter-Stewart definition for me. Do you know what Potter-Stewart is?
Supreme Court Justice.
Supreme Court Justice.
Defined what?
Defined pornography.
Yes.
The big issue about pornography came up.
I'll know it when I see it.
Right. I can't define it, but I'll know it when I see it. So I don't know, 6 beat. I mean, I see all these rules about high-grade heart block. This is high-grade heart block, okay? This is a thing called paroxysmal AV block, okay? And it's always set up, at least in my experience, with some kind of ectopy, PAC, PBC, some ectopy. Now, you want to say the mechanism is bradycardia-dependent block. Is that what you're going to say? So I was hoping you'd say that. So that, if that's the case, in other words, you think because this happens here and there's a bit of a pause, that even though these are going fairly rapidly, we have phase, what, we're going to call this a phase 4 heart block type gig?
Yes.
So if that's the case, when this person goes to sleep at night and has a rate of 40 beats a minute, how come they aren't in high-grade heart block? I mean, if they've already demonstrated that they can have, so what you're consuming is saying is bradycardia-dependent heart block, how come when they're even more bradycardia, they never have heart block? That's because I think it's wrong. That is indeed what people say. I think it's totally inaccurate. I do, because I've got 3 or 4 of these. I don't have 50 of these, and in every one of them, I've looked at the Holters at night. Every one of them has slow heart rates where you never see it, and every one is started by a premature, and every one is ended by a PVC. Okay. How does that make it? I think it's personally, I think it's micro reentry in the AV nodal air, in the His-Purkinje system that keeps giving it retrograde concealment until either you die because you don't have something that stops it, and you can die from this. So whoever wanted to pick treatment, somebody pick treatment.
Pacemaker.
Pacemaker.
Here's
So
the
to
lab.
come to her defense a little bit,
Well, why do you want to come to her defense?
because she spits the common dogma that you hear.
Right, that I hate.
Place.
Everyone has their break points.
Yeah, no, I agree with you.
This is
but-
one of mine. So I said that's the common dogma.
Yeah.
But the reason I don't buy the common dogma is based. You said the right thing. If you were in front of somebody else, they'd say, wonderful job, but you're in front of me. So I'm going to challenge the common dogma because I know it doesn't make sense.
How would you answer the question if it were a board question, huh?
Like
You'd probably say phase 4
like I
block
did on that
because that's-
ACLS test. I would give them what they wanted, and then I would write a long dissertation of how stupid they are. So here's what I'm saying to you, though. In deceleration-dependent block, which is what's called bradycardia-dependent. The reason in deceleration, that was a Charlie Fish term. I think it better, because sometimes it's 80 beats a minute you get blocked, right? So it's not really always bradycardia. So deceleration-dependent and acceleration-dependent blocks. They're fairly consistent. So if you really have like a left bundle branch at a heart rate of 50 and 60, you'll have it usually at 30, 40 and leading up to it. In these patients, when I've studied them, they never have heart block at slow rates during sleep, much slower than this. So it got me thinking about it and thinking, then what's going on? So it's always set up by a premature. Prematures, big deal. You see prematures all the time. These are rare. These are relatively rare. I've got maybe 3 or 4, like I said, in 40 plus years. I mean, I don't have, 30 cases like this. And I actually think what happens is the premature sets up some micro reentry we can't see that persists in causing the block until something interrupts it. So this patient was studied by me in the lab. And so you see this beat here that you thought was a PAC? I'll give you a chance to change your mind. Here's the intracardiacs. What comes first, this or this?
The His comes first.
Oh, the His. By golly, the His comes first. So, you still want to stick with a PAC? How about, it's all you can tell from the ECG, but we're trying to teach you how to hone in on subtleties of the ECG. Little narrow, anteroseptum, 2 things live there. The anterior atrial septum, so you could be right, or the junctional. Well, paroxysmal AV block involves the His-Purkinje system. So more likely it's going to be something in the His-Purkinje system. I've only got a few of these, and most time we just put a pacemaker in. But this is example, and you see it'll just keep going. It just keeps going and going and going, and the rate will speed up as the pressure falls. It's still going, so where's the Brady-dependent block? All based on one stupid, poorly done electrophysiology study in a cell bath that Harold Strauss said the guy didn't even know how to make a thyroid solution, showing that the diseased Purkinje fiber can do this. I'm serious, okay? No one's ever replicated it over the years, all right? All the wonderful work by Pepe, Jalife, and others, they never replicated that. So I think it's just wrong. But you're right. George is correct. If you're in front of another venue without Prostowski there, you can spit it out. Or you can say, by the way, I was in a course with Eric, And he says, you're all wrong. So but this will cause death. This will cause sudden death. Absolutely have to put a pacemaker. And in this patient, I let this go. And then when I thought when the pressure was falling, I would put a PVC in, boom, right back, sinus rhythm, 1-to-1. Just PVC, okay?
So
Never went to the atrium.
The board type of question is often they'll ask you something like I think the chronic treatment is pretty self-evident, but they'll ask you for the acute treatment. And they'll ask you something like it's 3:40 in the morning or something, and the nurse flicks this to you, the patient's now fine and asleep again. And your next course of action would be da-da-da-da, yada-yada. And your answer would be you get your ass in there and get some temporary pacing going.
Fast.
So that's the board type of question.
Fast. So there's a time to cerebrate and there's a time to do.
It's a medical emergency.
Right. We can talk about this and we can have a legitimate physiologic discussion and disagreement, because I can't prove my point either. I think mine's right. I can't prove it. But we all know patient needs a pacemaker. This is a dangerous situation.
Right away.
Right away. You did well. So next time somebody shows you something like this, say, just a minute. I saw this Prostowski guy, and he said you're wrong. And tell him to call me. And I'll be happy to explain why they're wrong.
Somebody has a question.
Yeah, someone had a question. Yes, go ahead.
So my question's about the mechanism that you think is going on. So it was my understanding that the level of block was in the hiss. But what I'm hearing from you is that you think there's micro reentry in the AV node.
No, in the hiss. I think it's in the hiss.
Okay, I understand now. Thank you.
Yeah, this is just a thought. I mean, I have no proof, but when I've studied these people, I've started them. I've watched them like this. Just watched it happen in the lab. You're there. You have catheters, and you're not letting them. You're not going to let them do something dumb. Like go on 20 minutes, but just put a PVC in, stops. Okay, and then sometimes you can just put a PV in, start it. Okay, you put a PVC in, doesn't even make it up there, and then it starts, and it's always AH. Now again, I don't have 50 cases, okay, I have a few, but they've made me think mechanism, and I just don't get the Brady part, George. I don't know, maybe it's just, it's maybe I'm on a high horse here and I should be on a low horse, but as long as I'm not on a rocking horse, I'm still okay, so. Did you have a comment?
I have some slides about mechanism of this, and maybe, because it's not in the slide deck, I don't know if you can go, but I have some slides about the mechanism and how it starts and how it recovers. But I'll show that maybe later. But clearly, it's His-Purkinje disease. Almost every case I've ever seen, the patient has a bundle or bifascicular block.
Correct.
So
Me
take that as 99.9% they'll have bundle or bifascicular block. Is His-Purkinje disease, whether it's micro reentry or something else, no one knows for sure.
So I'm going to, the next one, we'll get to that.
Why would micro reentry cause the pauses? I'm just asking if you could point out to the audience.
Oh. Well, not the pauses, it just causes non-conducted beats. In other words...
So in other words, like concealed conduction.
Concealed conduction, yeah.
Something obstructing it. If there's micro-reentry going on, it's not...
So it keeps banging. So one of the theories, like, for example, I'm going to let... Can you get Ken's deck up? I'm going to turn it over.
You get my Klein-Ellenbogen-Prostowski deck at the very end. I'll help you find it while he's talking.
I don't have a Klein-Ellenbogen-Prostowski deck, do you?
He called his that.
Oh. So anybody want to opine on why you get Winky Bach? Why is Winky Bach occur? What do you think's going on? So what is Winky Bach? I understand you can tell me the ECG. Tell me the physiology. Yeah, and I know you can tell me the AH increases. That's not what I'm asking you. What's going on? Why is there a progressive increase in the AH interval? Did you ever think about that? What causes that? Right? Why is there this progressive increase? So this was opined in the early days of EP, and there's Mike Simpson did his computer model. I mean, no one knows for sure, but there are clues from looking at it retrograde. And our mentor, John Gallagher, was in part of this at the very famous Staten Island lab during the war, during the Vietnamese War. You all heard of that, right? We had to live through it. And there were the Green Berets, John Wayne and the tough guys. And then there was a group of people called the Yellow Berets. The Yellow Berets populated the National Health Service, the NIH.
Peace Corps.
Peace Corps. and there were some of the smarter people around, and that was what happened in Staten Island. So here's this guy, Tony D'Amato, who's just a routine doc on Staten Island, who gets this influx of Mark Josephson, Masood Akhtar, Ben Sherlock, John Gallagher, you name it, a who's who of American EP.
American Draft Dodgers.
Yellow Berets, as I said, all Yellow Berets. We'll leave the Draft Dodgers, but definitely Yellow Berets, who started the field. And then there was in Europe the Amsterdam school. It was Dirk Dorer, Hein Wellens, and that whole school. There was also a very prominent French school, but they would not publish anything but French. Paul Puech.
Archives
Maladie de Corps. They never published in English. So we never really saw a lot of their literature. But at any rate, there was this whole thing, and one of the early studies that I always thought was a beautiful demonstration was pacing the ventricle, and what you would see is VA Winky Bach. So you'd see a VA get longer and longer and longer, and then what would happen? Then it would turn around with an echo beat. VA, 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 echo. And that gave a bit of a clue, right? So that you could see, because you saw the actual echo and you knew the last beat turned around and came back down. So what does that imply? That implies it set up a reentry circuit in the AV node. Now, can we say for sure that it's not happening antegrade? So what a lot of people started to think was what's really going on in the AV node antegrade is there is delay, there's more delay, and then there's an attempt at reentry, but because of concealment with the next beat coming in it, you don't see it. And so you just get blocked. And so one of the theories for Winky Bach is a progressive increase with a final turnaround through the other pathway, the slow pathway, but with retrograde concealment, and they collide so you don't see it. Because retrograde, you'll get this phenomenon that you can see. Now, whether that's true or not, no one knows for sure, but it's one of the proposed mechanisms. So things have a reason, right? You don't just suddenly get, progressive prolongation. There's going to be a reason for it, right? So I like to think physiologically. And anyway, that's the theory I like. It doesn't mean it's the only one, but anyway, that's probably it's at least a tenable theory for antegrade Winky Bach. So if you can have that, why can't you have a concealed reentry loop in the His? I mean, it's theoretically possible, right? So I'm going to stick with that.
So this is an alternative thing, but if you have a PAC or a PVC that blocks, particularly in a patient as a bundle, what you do is you create a long HH interval. And that long HH interval, results in increased refractory period, and that's why you get blocked. You get blocked where? Below the His bundle. So these are the characteristics. Eric's already talked about